Release that mouse. So this is what you're doing at work? Eh? Online shopping? Hey, Mrs. Richards. Aren't you looking lovely today? You think you must be able to shop online? You don't need no more clothes. What you need to do is stick to the iSave plan so you can get your dream house. The key when faced with temptation is to walk, run, or roll away from it as fast as you can. And later on today, we're going to transfer some money to your iSave account using VM Express Online.
Okay, good evening and welcome to the Windrush Health Legacies, exploring health legacy across the diverse Caribbean population from a perspective of those who've traveled many afar. So we've got many people on the live with us today. We have Dr. Kevin Brown, who's chairperson of the Jamaican Diaspora UK branch. We have Rosemarie Thompson and Tony Kelly, who respectively will be talking on topics around cancer and diabetes, and I'll let them introduce themselves a little bit later on. So why are we here? Well, again, we're here to sort of explore the legacies really of those persons who have obviously been products of the Windrush generation. So we're exploring the health legacies inherited by the Windrush children. And we think this is obviously an important dynamic to sort of discuss and touch on today, given the fact that it is Windrush Day, 22nd of June. Hopefully you all donned your colours of your respective countries to celebrate today and celebrate the efforts of the Windrush generation. So big smiles, big work. It's a lot different to what we would have expected, I guess, with respect to, you know, having a social media platform to explore this, rather than celebrating our efforts in person in hospitals and in community centres up and down the country. But nonetheless, we are here. We are excited to discuss topics today. And first of all, I want to sort of introduce my guests. So first of all, I think as this is supported by the Jamaica Diaspora UK arm, we have our chairperson for that arm, Dr. Kevin Brown. If you'd just like to say a little bit about today and what your feelings are on today.
Right. Thank you, David. Well, you know, it's really a pleasure to be able to have this event today. It's pretty important for us to celebrate Windrush Day. It's a day that we had to, lobby for, and we finally got on the British calendar. And why is Windrush Day important? Because many Jamaicans, hundreds of Jamaicans, in fact, answered the call of Britain to come and help to rebuild the country after World War II. And prior to World War II, we had Caribbean nationals who were, part of the fighting force in terms of World War I and World War II. And after they got demobilized, some of them returned as well to live and settle in Britain, joined by hundreds of other Jamaican nationals who came over, some of them in course to seek a better life, many of them thinking they'd only be here for 5 years or less, and some of them ending up staying for a lifetime. You know, yesterday I spoke to a Jamaican lady. She came here in 1954, so, remarkable length of time that she has spent in Britain. And although she sees herself as Jamaican, you could also say she's very much as British as it gets, So the British story is certainly a Jamaican diaspora story. And one of the things that we wanted to achieve today is to talk about health. And why is that? Because in the midst of this COVID-19 pandemic, we have seen many reports now that have shown that African Caribbean people, and when we say African Caribbean people in Britain, we're essentially talking about the Jamaicans for the most part, right? And that's not to say that there are not other Caribbean nationals in the UK, but Jamaicans are the vast majority of African Caribbean nationals. And so, we know that it's been well reported that Jamaicans, African Caribbeans, Black people, Black heritage people, have been disproportionately affected by COVID-19. And part of the reason for the impact of COVID-19 in terms of the number of deaths and so on is related to underlying health conditions or comorbidities, as they call it. And some of these comorbidities include diabetes and several others that afflict African Caribbean people disproportionately. So, you know, the aim of this, and it's a series of events that we're launching tonight, is to look at all of these illnesses that affect the community. We want to talk about what they are, how you can prevent getting them, if at all, and how we can treat them if you do have these illnesses. And we want to look at all the range of treatments, both pharmaceutical and alternative methods as well. And we will be using a range of specialists or experts on this in the series to talk about these illnesses. And in this particular panel, we have Rose Thompson, who's a cancer expert. We've got Tony Kelly, who's a diabetes expert. And in the series to follow, we're planning about 10 episodes rather. We will have other experts as well speaking on those illnesses. And because for me, David, the key is that yes, we should lobby the health service and the government for better health equality outcomes. But I think there's a lot that we as a community should focus on doing for ourselves. We have experts that look like us, that can talk to us about these illnesses. And we want to tap into that expertise. You're a consultant ophthalmologist. We need to talk about eyes. The African Caribbean community has issues around glaucoma, cataracts. We don't talk about that enough, in my view. And so we're hoping to use this virtual platform via Facebook and YouTube to give out that information, to engage in conversation around these illnesses. But at the same time, from a diaspora perspective, we should also be looking at government policy as well. So, there's a wide scope in there, but it's all about health. It's all about looking at the Windrush generation and how health has affected their British experience and how we can come out of COVID-19 as a stronger community, right, as it relates to health and a community that is doing for itself what it can within the resources that we have to reduce the spread of these illnesses. And, we talk about the Windrush generation having these illnesses, but some of these illnesses are cross-generational. Sickle cell, for example, is cross-generational, and will be for a very long time. And it's a very unique illness for African, Caribbean, and Asian people. Cancer is pervasive. Prostate cancer is more aggressive in Black men. Diabetes is also quite widespread. So, I'm hoping we can touch on these illnesses, and come up with strategies to take forward. In terms of the Jamaican Diaspora UK, just to remind, people out there watching, that, we are a national organization that was set up all the way back in 2005 with the aim of protecting the interests of Jamaicans and also to assist in nation building. And so although we'll be focused more on the British experience and Windrush, of course, these health problems are also a challenge in Jamaica. And, we will be looking at options, available to us to also see how we can have an impact in Jamaica as well. So as part of the Jamaican Diaspora, we have created what's called the Health and Wellbeing group, which is chaired by yourself, David. And, and this is part of your group's activity in terms of reaching out to the wider community. And the final thing I'll say is that, I'm also the UK North representative on the Global Jamaica Diaspora Council. And so that council is a consultative forum chaired by the Ministry of Foreign Affairs and Foreign Trade in Jamaica. And so what we want to do is also use that platform to sort of ensure that the Jamaican government is also talking about health outcomes for Jamaicans in the country and overseas, and to also see if we can influence Jamaican policy as it relates to health. So, I'm looking forward to the rest of this, debate and panel discussion, and I hope that those who have joined us on Facebook will interact and use the comment section to, ask questions or make your comments, and I'm sure we'll capture those and read them out during the course of this event. And as I said, also, if anyone wants to get in touch, I'm sure David, we'll give out the email address for the organization, because we're always keen to hear from people. And you can join the Jamaican Diaspora UK. We take membership, and we can only get stronger if you become members, and we represent a wider cross section of the hundreds of thousands of Jamaicans who live in Burton. And not just, I keep saying Jamaicans, but do bear in mind that when I say Jamaicans, I'm referring to first, second, third generation, people who are born here of Jamaican heritage, who may see themselves as Black British but have a Jamaican parent or parents. You are part of the diaspora family. So I just want to make it clear that it's not the definition is broad in terms of who is a Jamaican diaspora, and you don't have to be born in Jamaica, but of course, as long as you have that connection and heritage, then you're more than welcome. So thank you very much, David. I'll end there.
Thank you very much for the summary there in terms of from why we were formulated and why we have this health and well-being arch or arm to the Jamaican Diaspora UK, and to end there to talk about the fact that we need the unity in order to bring things to focus and to get movement and change that is required so deeply in our population. And as part of the Windrush group, yes, we do aspire to sort of help facilitate the movement and change that's required in terms of health and well-being. And as you can see, I've got two of the panelists here with me today to discuss their backgrounds as well. So without further ado, I'll firstly introduce Rosemarie Thompson, who is founder and chief executive of BME Cancer and Communities and co-founder of Sistas Against Cancer. Rosemarie, tell us a little bit about your background and maybe a little bit on Windrush as well and what it means to you.
Yeah, thank you, David. We've been celebrating it all day. As you can see, I've got the colours on. Been on Facebook. My daughter is an art illustrator. She's done a Windrush print to raise funding for our charity, and apparently it's selling well. But I kind of firstly, I know Kevin's talked about British-born Caribbeans, but actually I was British-born, but I always knew I was a Jamaican. And in fact, I was born in '56 in the city of Nottingham. City where the story of Robin Hood is, and we lived on Robin Hood Chase. And when I was about 2 or 3, the Prime Minister came from Jamaica, Mr. Manley, and he came to pick me up. I'm one twins, but I was always shy. So he went and picked my sister up instead, my twin sister Maureen. And that is the Pathé News now, that photograph. He came really because there were so many Jamaicans that came to Nottingham. So we've grown up, even though we eventually, moved from Robin Hood Chase to an area that wasn't so Black, we were always involved in the church. And so I know my culture. And unfortunately lost my mother to breast cancer in 1976, at a time when I come from a family of nurses. Always wanted to be a doctor myself. And I did succeed with that because I actually have an honorary doctorate from Nottingham Trent University, but my field is cancer, always interested in it, particularly because my mother chose prayer and faith over conventional treatment. And I didn't even know she had cancer until about 6 months before she died, whilst I was training. So that has been my passion to start a charity, because even though, there were cancer services then, it was quite difficult to go through treatment. It still is, because we found out later on we had a family history, and my twin sister was diagnosed at 34 and it returned and the GP didn't spot it. So we lost her at the age of 45. And then my other sister was diagnosed at 42. She didn't have some of the treatment, but actually, again, it was missed. So we lost her the year before last. And then I was diagnosed at the age of 59. I'm here basically. As Jamaicans would say, Medea. And as a result, we started not only BME cancer communities, BME, I like to call it BME. It means Black and minority ethnic here. Then some add in Black, Asian, and minority ethnic, but the official government term that we didn't choose is BME. And I am the chief executive of BME Cancer Communities. I'm also the author of 2 reports on prostate cancer and Black men that were launched in the House of Commons in 2013, 2014 by our champion, David Lammy, MP. The first was about prostate cancer in Black men. The second was a call to action. And so we did that call to action in Nottingham based on that Hear Me Now report, which you can see on our website, and actually set up a community-based clinic in the Black community where we checked over 300 men and saved lives. We started a support group before called Friends and Brethrens, which is a thriving charity now and is supporting over 40 men. But when I was going through breast cancer myself, and it couldn't be seen on the mammogram, because to be honest, when it happened to me, it was a bit of a shock that it was stage 3. But it was because it couldn't be seen on the mammogram. It couldn't be felt by anyone, even though I'd been checked every year. So I went through that journey as other women would and met them and realized that they were not getting the support that they needed. Even as far as wigs and, you know, I have a swollen arm because of the surgery. You know, even when I went to get a sleeve for this, they were only giving out pink ones. So I fought for this and for the women. Last year, one of our plastic surgeons in Nottingham, she set up, was it last year? Yeah, end of last year, Black History Month, October in the UK. We had our first breast cancer and Black women conference at King's College London with one of the plastic surgeons who was originally from KCL and is now at Nottingham, and we want to do that annually. And Sistas Against Cancer is not just for patients, it's a support group that is still under the BME cancer communities because they're not ready to go independent yet. We hope to make them a charity like ours, but we raise funds for them and they have their own bank account. But the reality is I found women who basically needed help, and they were carers as well. So it's for patients and carers. I have won Windrush Awards, one local, another national. I've got Phoenix Newspaper Award. There's multiple awards. But the greatest pleasure for me and the greatest satisfaction is when we replace tears with smiles. Even this morning, I was on the phone to a sister. We helped to start another charity called Cancer Survive UK in Manchester. And Marcella, who came to me through the reports, she's now Chief Operating Officer there. And she called me this morning to say a young woman, basically, she'd just been called about another young woman. We've been on the phone the whole time. COVID-19, I've lost family members, I've lost friends, a whole load of people, and my sister-in-law is recovering in Wales now. And she basically is, COVID-19 has some problems that happen afterwards. So she had diabetes. So I'm glad that Tony's here on the line as well, because that's his field. But I am a radiotherapy radiographer and information and support now. I went to work with a charity in 2003 and left the NHS to do that. And that charity was started by a Chinese woman, but I left that to start BME Cancer Communities when they ran out of funding. And it's hard to keep going, as you all know. And I hope you'll not only support Jamaican Diaspora UK with your views and listening, but also we're going to do some webinars on cancer from our perspective. And as Kevin said, we're not just interested in conventional treatment, we're also interested in what we know works and what has been working in the Caribbean as well. And we'd like to see more medical herbalists who are trained in both botanic, plant biology, and in conventional, so that we know the doses to give. We had the first food, nutrition and cancer conference in 2012. And we raised awareness about the importance of vitamin D then, because it can actually, deficiency can help to contribute to some cancers and certainly to MS as well, multiple sclerosis, we believe. So there's a lot of work to do, but we'd really like to make it culturally competent, not just to Jamaicans, but to Caribbeans. You know, we are working with Africans, but you know, Jamaica has been kind of where we come from. That's what we know, and we really would like to put Jamaica on the map as far as people understanding that we are professionals as well.
Yeah, fantastic, Rose. Thank you so much in turning tears into smiles. That was a beautiful thing there, really, and you know, empowering patients to make those choices that are required in regards to their journey. Before I bring in the next speaker, I just want to say that this forum is partly sponsored by Victoria Mutual and Jamaica Moves, and we thank them for their support in regards to our journey in this health and wellbeing forum. Now, without further ado, I'd like to bring in the next guest to sort of give us a little bit of a flavour as to his background. His name is Tony Kelly. He's a diabetes and patient lead for NHS Birmingham and Solihull CCG. And it's my pleasure to bring in, last but least, the great speaker. I'm really interested to hear his views now on diabetes. So thank you, Tony, for joining us this evening.
Thank you, David, or should I say Dr. Burton, because you are a medical doctor. But I have to start with my health disclaimer for the listeners on Facebook. My health disclaimer is that I'm not a healthcare professional. So they need to hear that loud and clear. So when they start phoning in or tapping in their question, they know they're not speaking to a doctor. Because sometimes people get confused and say, oh, we want to speak to Dr. Kelly on the program. And I say, no, I'm not a doctor. However, we are celebrating Windrush 1948. It's actually the same year that the National Health Service was formed in Britain, 1948, the same year. So both of them 72 years old this year. And my starting point is that my mother in 1953, my aunt before her in 1952, and my other aunt in 1956, all left the parish of St. Thomas, Bath, St. Thomas, Jamaica, to come and train as nurses in Britain. So that shows they're part of the Windrush generation, 52, 53, and 56. And so they trained as nurses, etc., etc. There are lots of doctors in the family as well. But my interest in this topic of diabetes came about when, first of all, I am the secretary of the West Midland Regional Council of the Jamaican Diaspora UK. And as Kevin, our national chair, said, we want people to become members of the organization because unity is strength. We don't want to be in silos. We want to work together. So that's a plug there for us here in the West Midlands. Whether you're in Walsall, Wolverhampton, Coventry, Solihull, Dudley, come and join us at our monthly meetings. They're on webinar at the moment. And even I've gotten used to webinar, and I'm the biggest technophobe out there, trust me. But back to the situation. So born in Britain, but at an early age, my parents sent me to Jamaica, the land of their birth, to a place called Whitehall in St. Thomas. So I was raised by my aunt, Mrs. Ina Watson, God bless her, she was a teacher, and her husband, Mr. Wilfred Watson, and my grandmother. And as a child growing up back then, in Jamaica, would I say nosy or fast? I would see relatives of mine who had, starting from the top, strokes, blindness, heart attacks, kidney dialysis, having to go into Kingston because of renal failure, kidney failure, lower limb amputations, and also some who died what we call prematurely. Gone too soon is the well-known Jamaican saying. So in their 30s, 40s, 50s. I would ask all these relatives of mine, what's the matter with that one, that one, that one? And all I was told back in the Jamaican time growing up was they have a touch of sugar. All of you listening will know how it was always referred to, diabetes, a touch of sugar. So they basically minimized or trivialized or downplayed this medical condition by referring to it as a touch of sugar. Fast forward, I went to Micro Teachers Training College, taught in the high schools in Kingston, and then came back to Britain, the land of my birth, in 1979. So I've been back here since 1979, living with my wife and daughter in Birmingham ever since. But then, David, 16 and a half years ago, my wife noticed the 4 key symptoms, and I'll demonstrate them for you, called the 4 T's. T for tired, T for toilet, T for thirsty, and T for thinner. Thinner meaning losing weight. So tired, toilet, thirsty, thinner. I was displaying all 4 of those classic symptoms, and then my wife kept saying, something's wrong with you, something's wrong with you. But there's me here as a man, you, David, and Kevin. Most men do not do doctors. Most men are not in touch with their feelings. Most men are not in touch with their emotions. I will put my hand up and say, I was one of those men. So for about 8 years, I've never been to my doctor's surgery back then for them to do my annual checkup on anything. So when I went in after my wife, in fairness, was nagging me, and she'll accept she was nagging me, you better go and see a doctor. I went with a vial, a sample of urine, and the doctor put the dipstick in it, and it comes up and it says, Mr. Kelly or Tony, you have diabetes or sugar, same thing, in your urine. And viewers, there's supposed to be no sugar or that or in your urine. So that's when my journey started 16 and a half years ago. I made what we call the lifestyle changes or the behavioral changes. And I've had this condition which runs in my family, as you have gathered. So it's hereditary for nearly 17 years this December. And I've never taken medication for mine. And that's to do, we'll come on to that later, the lifestyle that I lead, the complications at play. And I want us as Black people, African, Caribbean, Jamaican people, we need to hear that message. So I was at an event in Wolverhampton. I was asked to speak at an event in Wolverhampton 8 years ago this month, June, and Diabetes UK, who I no longer work for, I'm now independent, but they saw me at the event and they said, are you going to speak? And I said, yes. And I spoke for 10 minutes from the heart. And they said, come over to Macedonia and help us because you've got the gift of the gab. You can chat. You won't stop talking. Anybody who knows me. And we want you to go into communities. And this is what I want your listeners to hear, viewers to hear. I go to a lot of healthcare events. And all I hear them saying, even now to this day, they talk about hard to reach communities. I hate that with a passion. When I ask, what are these hard to reach communities? They say, oh, the African Caribbean, the Black people, the Asian people. I say, excuse me, are they on Mars? Are they on Jupiter? Are they in the rainforest? Are they in the deep blue sea or in the jungle? Please do not be patronizing and condescending by calling our communities hard to reach. I regard that as a form of racism because we make up the community. Go to Bristol, go to Toxteth, go to Antwerp, go to Liverpool, the Moss Side. You will find us. We're all there scattered around. So people in the healthcare profession need to, for me, get from behind their desk, their laptop, from out of their ivory tower, and go and engage with these so-called hard-to-reach communities. If I can do 150 community events per year, free of cost, alerting people, raising awareness about diabetes and the impact and the effect and how to go about changing your life. If I can do it, so can they. And my favorite saying, if Muhammad cannot go to the mountain must go to Muhammad. And that's what I've been doing for the last 8 years this month, June, going into communities free of charge. And that's the emphasis, free of charge, educating, making people aware that this is a condition which can be kept under control if they choose to do the right things. And I'll stop there for the time being.
Tony, thank you so much for sharing that. I think in terms of listenership there, Tony's 4 T's are really to be a testament to sort of diabetes. You want to go through that again, Tony, the 4 T's? The
tired, toilet, thirsty, and thinner. However, fantastic. I need to add to that, David, there are 2 others which also occur. Slow healing of cuts and wounds. Those of us who grew up in Jamaica know about tembe or sore foot. If you have diabetes, the ulcers and the sore feet are slow to heal. And then there is blurred vision. And I'm going to emphasize the blurred vision, because when people are in their 50s, 60s, 70s, they seem to think that because they're not seeing well, it's to do with them getting old. Trust me, 9 out of 10 times, it is the glucose or blood sugar forming in the blood vessels at the back of the eye, which is causing them to have the blurred vision and eventually to go blind. There are, I'll just quickly say, there are 4 Commonwealth countries where blindness is rampant from diabetes. They are Dominica, where I was 2 years ago, St. Lucia, Belize, and good old Jamaica. To see Rosemarie and see you, David, and see Kevin, and have my sight. So I'm saying to people, you must go and get your eyes checked on a regular basis. And you also must go and get, in Brittany, we have the healthcare service. And the same way you have your MOT of your car or your mechanic or what have you, you see your car done, checked up. Our body is far more important to us than that junk or metal, the car, the motor vehicle, the truck. You need to go yearly or annually and get your MOT done, your test done, because diabetes can remain in your system for 10 years, having its wicked way at you, and you're none the wiser. I'll stop there for the time.
Tony, I couldn't agree more, and that's a very nice segue into.
Hello.
So, hi, Tony. We can hear you. We can hear you. It's
we
very
lost
nice.
each other?
No, we can hear you. We can hear you.
Hello, David.
Yep, you're still there. You're still on. You're still on. We can hear you.
Not sure what's happening there.
I was saying, Tony, that it's a very nice segue into
I'm still here, but I said I'd stop there for the time being.
Okay, that's great. Thank you, Tony. What I was saying is, Tony, that was a great segue into where we are now.
You're hearing me? Oh, all right. Okay, yes, so I'll continue then, since that's the case. So
go ahead, Tony.
I'm on this mission, and I go to Gurdwaras, churches, mosques, residential homes, colleges, universities, Birmingham University, the University, Birmingham City University as well, Aston University. I go to events and I try and get people, but I do focus on our African Caribbean people, Black people, to say, you need to come to the event. You need to hear of the things that have to take place to keep the complications at bay. With due respect, yes, you are a doctor, Dr. Burton. We've just recently had the Public Health England report done by Professor Fenton, who is actually from Jamaica. And we're proud of the fact that this is Professor Fenton from Jamaica who led that report. And they talk about, the word they use is comorbidities. They talk about the underlying factors for COVID-19, especially in reference to Black people, is diabetes is an underlying health issue. Heart disease is another one. Dementia is another one. High blood pressure or hypertension. And there is chronic kidney failure. And of course, to add to it, lack of vitamin D. Now, when I go to these webinars or conferences, especially during this lockdown period, I say the amount of people, Black people dying in Britain and in America is alarming, disproportionate. But then one has to ask, Jamaica's deaths from COVID-19 happens to be 10. So we need to ask ourselves the question, and most of the Caribbean islands are in the very, very low figures. Some haven't even gotten to double figures yet. We need to ask ourselves the question, put the comorbidities aside for a minute. What is happening? Why so many Black people are succumbing to this COVID-19? And I'm afraid my take on it, it's got to do with the socio-economic factors. It's also got to do with health inequalities, which Rosemarie Thompson has spoken about in terms of what she's tried to do for Black women going through cancer and so on, and to do with systemic racism. Because if they're calling us hard to reach communities, we're so far away removed from them, that in itself tells you that they're not engaging with us. And that's a factor. there is 10 billion pounds spent every single year in Britain by the National Health Service on diabetes alone. That's 1/10 of the National Health Service budget, 10 billion. There's some countries in the world that don't have that amount of money as their gross domestic product. We need to say to people, you need to get people on awareness raising courses. Some people like to call them education courses, but some people say, well, that sounds too like classroom. But people need to be educated about what they need to eat, what they need to do. Jamaica has this thing about Jamaica Moves. So it's getting people to be more active, more physically active, moving more, getting the heart muscles so that it circulates the blood better. Because I, for one, I do every week before lockdown, I go to a Pilates class. I go to a yoga class. I go to an aquarobics class. And let me tell you, folk, especially in the Caribbean, I can't swim to save my life, but I go into the water and the instructor is there playing the music and you're moving your hands and your feet to the beat of the rhythm. And it is one of the best classes. So Pilates, fantastic. Aquarobics, yoga. I do badminton every week. And wait for this, viewers. Every single week before lockdown, I went to a Zumba class. And for those from Jamaica, me's the one dege man in a Zumba class with up to 25 or 30 women. And I said, well, I'm the rose amongst these thorns. But on a serious note, I'm there because I've seen firsthand in St. Thomas and St. Elizabeth and Kingston, the suffering of relatives of mine in Jamaica. I was on BBC national television live for the 70th anniversary of the NHS 2 years ago, the National Health Service. The very first question the interviewer asked me on live television, so Mr. Kelly, you're a diabetes sufferer. I just erected myself up and I said, excuse me, I am not a diabetes sufferer. I am living with this medical condition. I am managing and controlling it. Diabetes is not managing and controlling me. So please never refer to me as a sufferer. Admittedly, there are people who have to go and get kidney disease, chronic disease, or blind, or heart attacks, and so on. Yes, there are sufferers out there. Touch wood, fingers crossed. I hope not to be one as long as I can live.
No doubt, Tony. Thank you so much. So, Tony, you really opened up a discussion forum here in regards to the Public Health England report. I'm glad that you mentioned that.
I'm not getting any feedback here. But as I said, I go to events and I have the slides and the projector and I have the stuff I give to them and I explain to them, and people said to me, gosh, you're so motivated, Tony, you motivate us. I have an issue with doctors. Right. Okay. I need to stop now. Okay.
Yeah. Tony, thank you very much. Thank you so much. So you've touched on something that is at least quite nicely into what we wanted to focus on next, which is the public health inquiry into COVID and its disproportionate effects on the Black and Asian and minority ethnic community. As a group, we took the initiative to write to the Secretary for State of Health to acknowledge the fact that we would like sort of a more active response to the inquiry. Obviously, the findings of the inquiry were established, but the Secretary of State was not able to sort of provide that recommendation in a timely manner. And we have worked tirelessly to try and recommend some findings from our own sort of research from a small focus group that took place in the early part of this disease course. And so we welcome the fact that these recommendations have now come into fruition. And as Tony Kelly has already illustrated, Prof. Fenton took a role in in collection of the data for the findings. But I'd like to ask the group really what we think of the report itself and working up to the report itself in regards to their views really. So I'll open the floor for discussions in regards to the COVID inquiry and the report itself.
Right. Well, David, in terms of the report, it was one of the responses by the government, I think, to appease concerns that people had regarding the disproportionate impact of COVID-19 on Black and Asian communities, and you know, that was something that made it into the mainstream media fairly early on into the pandemic. And you know, we welcomed the review. We welcomed the fact that Professor Kevin Fenton was of Jamaican heritage. You know, we're very proud as Jamaicans, and we had you know, expectations that a thorough review would be done, covering all aspects as to why COVID-19 was so impactful on our communities. You know, the first report, much to our surprise, was just a sort of statistical data dump, you know, with no recommendations, you know, or anything of that sort. It didn't reflect any of the community engagement activities that Professor Fenton had undertaken. And we were quite surprised by the nature of the report. It then emerged through the Health Science Journal that apparently a draft of the report that had recommendations in it was censored by the government. You know, how true this is yet to be known, but nonetheless, you know, in the following days and weeks after complaints from organizations up and down the country, the government said they would publish a second report. So there are now two public health reports, one with a lot of statistical data analysis and another one with recommendations that reflects a more wholesome view of what actually affected the communities. And it's a whole range, right? So the report speaks of structural racism, as Tony said, as part and long-standing health inequalities, things that Rose Thompson talks about a lot in some of the work that she does. And also it spoke about these underlying conditions that we have that are pervasive in the African Caribbean community, such as diabetes, hypertension, etc. So I think that report presents some of the major aspects of why COVID-19 has been so devastating in the African Caribbean community. And it has several recommendations in that report. And my message to the community and any organization that is listening to this webinar is that we must now look at those recommendations and hold the government to account. You know, hold the government to account to say, now, you know, here's a report that was a government commissioned report, right? It has several recommendations in it, and we would like to see a follow through. Because one of the things that's not stated very clearly in this report is the action plan, right? Because that's the next stage. What is the action plan now to bring these recommendations to reality? And so that we can see some real change. Because some of these recommendations touch on issues that we know about. They're well documented. The campaigners like Tony and Rose and others have spoken about these challenges for years across a range of health outcomes, you know, not just physical health, but mental health in the Black community. So, you know, if you look at the seven recommendations, the first one talks about the need to look to collect ethnic data, you know, and to record it and to analyze it. I mean, one of the shocking revelations from this pandemic is that the government actually doesn't record ethnicity when someone dies. It's not recorded on birth certificates, you know, and I was so surprised by that because ethnicity profiling is commonplace across the UK when you apply for a job, etc. So I was surprised that it's not recorded when you die. And so that was one of the problems when we were trying to sort of understand who was dying from COVID-19. The other thing that the report recommends is around community participation in research. And again, you know, Rose can speak to this particular issue because she's done research and published reports on the impact of prostate cancer in the community. And the report clearly says that now is the time to ensure that research is not just high-level research, and, you know, but also engages with community groups who are best placed to understand the grassroots health implications across, you know, the sort of socio-cultural spectrum. So I'm hoping that more monies will either be ring-fenced or put aside for Black and Asian ethnic minority groups to access to do their own research and feed into the wider NHS body of research. The third recommendation speaks to improve access, experiences and outcomes of NHS, local government and integrated care systems commissioned services. So again, we know about these commission groups, and it's just making sure that they reflect a more diverse, collection of people looking at, the health requirements in Black and ethnic communities. And also, I won't go through all the recommendations, but essentially the rest of them touch on ensuring that, we have a better understanding of cultural competency around occupational risk, right? Because we know that BM staff or Black, Asian, minority ethnic staff found themselves at the forefront of the fight against COVID, but also by that nature of that very fact, we're also the ones to fall victim of COVID as well. And the whole other range, there are 3 more recommendations there, to look at as well around education and recovery strategies. So the point is, David, in summary, is that we now have the report. It's not the first report to look at inequalities in the NHS. What we want is to end the culture of reports, because that's what the government tends to throw to the community, to say, okay, fine, there's a problem, let's have a report. What we want now, what we're demanding, is action. Action, this report, action, the several other reports. Rose Thompson published a report on prostate cancer. Action the recommendations in those reports. That's what we're calling for now. End of reports. We have the data, right? And we will collect the data if we need, but we want to see action on the ground. That's what we need.
And I think that's a very key point there in terms of action plans. I think it's upon communities like ourselves to try and come up with ideas as to enforce those action plans with support of local charities, with support of local authorities, and so on and so forth. Before I go on to ask Rosemarie her thoughts, I would like to just touch on one thing. If you could stand in any questions that you have, we're obviously going live on Facebook, on YouTube. So please send in questions and we'll come on to the questions and answer session a little bit shortly. But Rose, please tell me your thoughts on
I'm actually looking at some of the questions here as well. Now, what I haven't said is that I've been going through secondary breast cancer whilst this has all been happening. So I've had to be shielding. So it's given me a bit more time to look at what's going on and join some Zoom meetings. So I did actually join the Zoom meeting that Professor Kevin Fenton actually was the guest speaker, and we were able to pose questions to him. So we kind of knew before the government released the report that we were suggesting recommendations. He had spoken to 4,000 Black and ethnic community leaders, and that he'd done it the right way. He'd gone out there, he had engaged with the communities, and actually he was talking to all of us. And Zainab Badawi, who is on BBC Hard Talk, was actually chairing that meeting. So we were shocked when the government released that report without recommendations. And I believe that Public Health have released it now, but actually it was a colleague of mine who is on another ethnic minority health email group that actually was called. He is an expert, Raj Bhopal, who was on the News in the End, to actually review that report. So I was talking to him. He knew there were recommendations there. We were all shocked that they were not actually shown. And the only reason we could think was that they had really shown them at that time. They were worried about what was happening with Black Lives Matter and that it might cause some problems. And we also had some of the senior nurses saying that there were recommendations. So to not release those recommendations for me was just really wrong, because you need recommendations. When I wrote my reports on prostate cancer, the first one was Hear Me Now, the Uncomfortable Reality of Prostate Cancer in African Caribbean Men. The first thing you do when you write those reports, you do your foreword and everything, the first thing you do is those recommendations, and then you repeat them at the end of the report. I was so excited when Prof. Kevin Fenton came into the role that, he's the most senior Jamaican, I think, in health that we've got at the moment. In fact, I have to say, in my over 40 years of working with cancer, I have only ever met one Jamaican registrar. We have some African doctors, but we rarely have them in oncology. And what was missing from the report was cancer. And normally, had I been well and operating as I normally do, I would have probably been on some of those panels. But nowadays you do them remotely, so I could have been asked. But what I do know, Kevin, you mentioned about the fact you didn't know whether there were recommendations or not. You know, we've got people like Yvonne Coghill, who was one of the first Black women doing research around Black women and their progression in their careers, and she commented on it as well. So I do believe it was deliberately left out. And I'm surprised that Kevin wasn't on the news either, but sometimes when those things happen because you work for a particular organization, you may not be allowed to speak. So thanking Raj for actually doing that. I see that there are some questions as well, David, about COVID-19.
Yeah, so let's keep on track with the public health inquiry. Tony, I know you touched on it a little bit there, but could you tell us your thoughts really on the public health inquiry, and maybe touch on the recommendations, if you will, as well. Thank you.
Well, for me, yes, I've had the inquiry. It's been very rushed. A lot of it was a database, quite analytical. Then eventually, as Rosemarie just mentioned, the findings, the recommendations were sort of like tagged on afterwards because of there's a lot of politics and politics being played with Black people's lives. And I'm saying loud and clear, it has got to stop. It's either all or nothing. No half measures here. Everything should have been released in one foul swoop, and then we wouldn't have this situation that we're now facing, where it's drip, 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 drip. It's the same cumulative effect, and we've got to get around that. And government officials and Public Health England and the National Health Service and everybody else involved, from Boris Johnson from top to bottom, need to treat Black people with a bit more common sense, with a bit more sense. We're not idiots, we're not fools. But coming back to it, there's clearly a discrepancy in terms of when I talk about race, social, economic factors, when I talk about racism, when I talk about health inequalities, that's clearly showing. And COVID-19, I'm sorry to have to say it, but for us, it's been a wake-up call. It has really hit the nail on the head to say, hang on here, I'm not for 1 minute denying we have all of these various other factors which we need to address in terms of health, underlying health issues and so on. But those of themselves also need to be addressed as to why more people have diabetes, why do more people have hypertension, why do more people have kidney disease and chronic kidney failure, etc. We need to look at the whole thing in a holistic approach and decide, okay, let's go back to basics, if we want to use those words, and carry forward now. I don't want to 10 years time, we're still deja vu, chasing our tail, going around in circles on this, because some of us, the likes of Rosemarie and myself, who have been around for a while, we've been there, done it, worn the t-shirt. And in fact, whatever's in the report and the recommendations, we don't want them to gather dust on the shelves. That's my issue, because I've been through other reports, 40 years living in Britain. And oh yes, there's a big hoo-ha about it, a song and dance, almost like a carnival type celebration. And then it gathers dust on the shelf, and 10, 15 years time, we're revisiting it again. No, we want to see fundamental changes. And this is why I admire the young people coming out in terms of the Black Lives Matter and making their voices heard. The silence, the deafening silence one used to hear ages ago is not going to be anymore. The future generation who we're passing the baton on to, they won't accept that.
Yeah. Thank you, Tony, for that.
David, can I just say something?
Please do.
Yeah, it's really important for us to, because I noticed somebody's put a question up about this. You can focus on what we call autoimmune diseases. You can focus on what conditions we're actually getting now. And actually, we know from the COVID-19 Office of National Statistics report that actually most of the people, well, the majority of the people who did pass with it had underlying conditions. I mean, thankfully for us, our sister-in-law survived, but she won't mind me saying she's had to have 4 toes amputated and she can't move one arm after this. So she's not survived without some problem. But the reality is, it is not just about underlying conditions. And I am really standing up strong against people saying it's because we've got underlying conditions. How did we get those underlying conditions in the first place? I've been on a Zoom meeting with some of the top geneticists because we actually did the consultation on the 100,000 Genomes Project in the UK, and it's around the world. There is a real investigation into genes now. But one of the things we know from cancer is that even, from my family, we've lost people, more than one person, to breast cancer, but actually only 5 to 10% of cases of breast cancer are because of inherited genes. And sometimes you may even have the gene and not get it. It makes it worse if you have an unhealthy lifestyle when you have the gene. But just because we've lost people doesn't mean everybody in the family is going to get it. So we don't want to hear this story. Yes, there may be some people who are predisposed to certain things, but to say that a race is genetically predisposed to things is wrong. What we need to be looking at is further back. There's a study in what we call epigenetics now, and epigenetics really interests me because we used to think that, apart from obvious inherited mutations in genes, that children are born with a blank canvas and they can actually be healthy and live well as long as they have a healthy lifestyle. But what we're now discovering, and what we discovered with cancer, is that stress can change your genes in tiny ways that can then be passed on. Not just stress, but what you go through can actually then be passed on to future generations. And when you think of slavery and all that we've been through, and even the fact now, many people who are in our group, the support groups, particularly the women, they're not just patients, they're carers as well. So they may have breast cancer, but they're still having to care for young kids and basically elders, and it's a very stressful thing. So, they sometimes do not even manage to keep all their appointments, or the other thing that Kevin mentioned is the funding. We have done over and over again, and with my colleagues who I've worked with over 10 years, the BME Cancer Alliance that was funded by the National Cancer Action Team before this present government took that funding away. We went to Parliament with 10 recommendations on cancer inequalities. And, I know from working with the charity, because we tracked where all the BME and socioeconomic deprivation funding was going in the early 2000s. And 60 million was made available. And when you look at the Beyond the Barriers report that we did, 98% of that funding did not come into the BME community. And that's what bothers me. We have really struggled to keep the charity BME cancer communities going, because when we apply for funding,
so we've got to really try and focus. We've got to really try and focus on trying to get that infrastructure money into the community. Yeah,
exactly. And actually, the best way to focus it is if we have what I call BME culturally competent researchers.
Yeah, perfect. That's great. And we need to make sure we get those researchers within our
So we're encouraging our young people, and
perfect, exactly,
with those who are researchers.
I agree. So fantastic. Thank you so much for sharing that, Rose. The Windrush Health Legacy, an exploration of health legacies inherited by the Windrush children. You've heard it here first, ladies and gentlemen. Tonight's event has been brought in partnership with Victoria Mutual. We thank them for their support, and also a mutual partner, Jamaica Moves UK, hosted by Corey Hyde. Thank you so much for your support. Thank you so much for your endeavors and taking this project forward. And also I'd like to thank our panelists this evening for giving their insight, their tidbits in regards to their feelings on the Windrush generation and how health matters. Now, I think we're heading towards the end part of our show, and I think we should focus on some of the questions that have come in this evening. So the first question I think that came up here was from Nathaniel Pete. And the question here is, what is the panel's response to MP Hancock's announcement that vulnerable groups, underlying health conditions, including diabetes, hypertension, heart disease, and Black and other ethnic groups will get vaccinations first? So what are the group's thoughts on that particular concept? Well,
do you want me to answer that?
Yeah, please.
Or Kevin, do you have something to say?
We got short snippets.
Well, I can briefly speak on it, and then you guys can chime in as well. Well, first of all, let me just also as David said, thank our sponsors, Victoria Mutual and our partner Jamaica Moves the UK for supporting this event. With respect to Matt Hancock and what Nathaniel Pete was saying, and Nathaniel, by the way, is the UK South representative on the global Jamaican Diaspora Council, and regarding that whole suggestion that of who will get the vaccine first, the thing with vaccinations is that they have been politicized. They have been politicized, and so there is some level of skepticism around vaccines. So it's a difficult question to answer because there are unknowns. And what do I mean by that? So we've been told that vaccines should take several years to develop, and it appears in regards to COVID-19 that we're now seeing a sort of fast-tracked approach to vaccines. We've been assured of a safety regime that's being followed to allow for these vaccines to be introduced without any sort of adverse effect. But nonetheless, it does seem as if these vaccines are going to emerge much quicker than one would expect. And I know, David, you're the medical expert here, so maybe you can also give your comment as well. But it would sound logical that those who appear to be at the greatest risk should receive the vaccine first. But I think the government needs to do more around assuring us that all the steps required to produce a safe vaccine have been taken, and that there have been no shortcuts, and all the trials that were meant to be done, I think first on animals and then on human beings, have been done, well documented, and we know and understand these vaccines very well. So I know that there is a need for a vaccine, but what we wouldn't want is one that's rushed out and then unfortunately has an adverse impact.
And Tony and Rosemarie, would you like to share your thoughts on the news? I think they're muted.
Yeah.
Tony.
Sorry.
I think Tony's muted.
Oh, I'd like to hear your thoughts as well, David, because
Sure.
This man is a doctor, an ophthalmologist.
Tony's back, by the way.
Tony's back. Let's hear Tony. Yeah. I'll chirp in, but I think it's good to hear the thoughts of the group. So, Tony?
I am not. You can't treat us like guinea pigs. We're in the experimental stage. And I will take you back to the Tuskegee event of America's 1921, where men who had no form of syphilis were actually injected with syphilis in order to carry out an experiment. That happened in America. And these were African Caribbean men, Black men in the States. We can all look it up, the Tuskegee experiment. And we need to be mindful. Vaccines and vaccinations take years. COVID-19 is a very new phenomenon, okay? So this idea of, oh yes, and we'll get the Black people tested first and we'll guinea pig them and try them and so on. We need to be very mindful and very careful. We don't know what is in the vaccines, and Kevin himself mentioned about it being safe and being tested on. Some people don't even like vaccines being tested on animals. So there's issues around that. The ethical issues there have to be dealt with. And I'm afraid I will not be at the front line as somebody who would want to take a vaccine when we're still unsure about what this COVID-19 is. We're still in the dark. We're still ignorant. So for me, at the moment, it still remains a no-no. That for me and what David Hamilton is a couple.
I've got what you're saying there. So I think the thing here is that with any particular type of vaccination, two criteria, at least in my eyes, have to be met, and we've touched on them already. But the product itself, first and foremost, has to fit a safety profile. If it's not deemed to be safe, then it won't be used in the public domain. The second thing that has to be fulfilled is that it has to work. So it has to have a degree of effectivity in regards to controlling the problem at hand. What I will say in regards to vaccinations is that there are challenges that exist in the development, quite obviously. Okay, and you're right, Tony, in voicing those challenges. COVID in itself is a tricky virus because of the degree of how it can change over time, and so that's just over the short term. So we know that, but I feel that as long as the criteria are met from a safety and effectivity point of view, then the use of a vaccination it should be something that we all consciously hold to a high regard in regards to a treatment strategy. In regards to treatment also, I know this wasn't the question, but there are other ways of treating this particular virus. So recently, in the past week, 10 days, I feel as long as the criteria are met from a safety and effectivity point of view, and the use of a vaccination, it should be something that we all consciously... I'm hearing myself now. So, yeah. So what I was referencing there was in the past week to 10 days, we've obviously heard that there are treatment trials that have ended a little bit earlier because of dexamethasone, for example, being something that is have been found to be very helpful in treating patients towards the latter part of the disease itself. So as long as those two criteria, back to vaccination, as long as those two criteria are met, then I think we're onto a winner in regards to treatment. Now, in regards to the Black population and the treatment of which, we need to make sure the treatment works. And the way of working that through would be to have people within all different types of communities, Black, Asian, Caucasian, etc., using the vaccination to make sure that it works. Because if it doesn't work within the community that we feel it should work in, then it's a non-starter, and it gives then rise to a further feeling of fear that there's not a medication or treatment that's out there. I completely acknowledge the fact that there have been experiments in the past that would be deemed in an ethical light to be deemed something that would be negative. I completely hear that. But if we follow those two shiny principles of safety and effectivity, then I think we are doing ourselves a great service in that regard. Now, the question itself is a very interesting one because it points to the fact that we are an at-risk group. And that's been shown through multiple studies in regards to risk. However, a part and parcel of those risks will be down to socioeconomic factors, and that's been highlighted by the recommendations of the report. So getting on top of that, forums like this in terms of trying to figure out ways of how we challenge that, how we come up with action plans to help reduce those socioeconomic inequalities, to uplift persons who are at risk is a very good way of trying to reduce that burden on Black communities. And that's the other thing that I would add in there. Reducing that risk is first and foremost, and that's something that we can do, and we can champion that sort of pattern to reducing the inequalities. Okay, so any other questions on that one? Or comments? No comments. So I've got another question here. Where does the balance lie between self-help and taking responsibility for your own health, or holding the government and NHS to account? Very, very good question. That's just from Jennifer Blake. Where does the balance lie between self-help and taking responsibility for your own health? I think I'll touch on that one. In regards to the practice that I have and the way that I treat my patients, I think it's very much a necessity to empower all patients to be able to have the responsibility of understanding their disease and condition, their condition being that of diabetes to how that affects the eye, for example, to glaucoma, and making sure they're aware of how that condition affects themselves. Because they may well be able to put in some lifestyle modifications, as Tony's touched on, that would help and afford them to reduce the burden of the condition on their life. So if you could put those lifestyle modifications in, then some of the treatments that we employ may, depending on your circumstances, may not be such a requirement and such a burden. But it also helps to understand the disease from a family perspective. So if you are at risk of a condition, your family relatives may well be at risk of that condition, and education is key in that regard. Education doesn't just stop in the school environment, it continues throughout life. It's a lifelong education in regards to your health, in regards to how you move from A to B, how you manage your money and finances, etc. And without sounding like a soapbox, I think that from a health point of view, we could always do better at sort of getting our patients to understand their conditions and to empower themselves to make those changes that may well be helpful in carrying out their activities. But we've also got to challenge ourselves into how we deliver that information in a manageable fashion, in a fashion that is accessible, because we want our patients to be able to resource that information. There's a wealth of information that's out there on the internet, and to find the right channels of information is increasingly difficult with the wealth of information that's out there. So we've got to be leaders as clinicians in giving that information, allowing patients to access that information so they can make those better choices and in regards to their disease. What I don't like is seeing patients who come in after several visits and don't quite understand where they are with regards to their diagnosis or treatment. And I think that's a disservice to patients across the board. And so I challenge my colleagues to deliver that as a standard model of care. And then that helps, obviously, with that empowerment to reflect future decision making and changes. So that's my thoughts on particular matter, where I balance on the clinician and government initiatives.
Can I just come in there, David?
Of course you can. Yeah.
Yeah, because I worked for the NHS for 26 years, and I worked for a charity for 4 years before we decided we needed to focus ourselves as experts on the Black and minority ethnic community, because there was clearly health inequalities from that time. And we know, for example, that somebody who has a good income and a good living standard can live up to 4 years longer than somebody who doesn't. We know that if you add in lack of education, remembering that some of our boys were expelled from school and some of our girls as well, and their education was affected by that as well. So it's not just about the types of conditions, it's about what happened to you. But in BME cancer communities, we have always sought to work with the community to change things. So when we use the evidence in the Hear Me Now report to get some funding from the clinical commissioning group, we had to run a community clinic on what was cost less than one senior radiographer's wage to run it for 80 months. And so my husband and I have gone without for a very long time. But reality is, from running that prostate cancer community clinic that we didn't call the prostate cancer community clinic because it was in the Black community, we called it Check Things Out, basically. In the same way that when we launched the report, we didn't just call it Hear Me Now, we just remembered Hear Me Now, as in posh English. We called it Hear Me Now and had everybody saying it, listen to us. So when we ran the clinic, we connected, we had the urology nurses there, we had the GP lead on cancer, we were connecting into all the GPs who, many of them were not actually even doing the blood tests that helped to pick up prostate cancer. It's not a definitive blood test, but we needed to do it for Black men because they were getting prostate cancer 5 years younger at the age of 45 and twice as likely to die. So as a result of doing that clinic, and we did it with the men that we set up the support group with, we had men there who were like support for the men who came who were afraid of, having the tests, and continued to support them. And as I said, we probably have over 40 men in the support group. And in the we launched it in 2012. One of the things that happened as a result of that report was that we were able to track them. We were able to put them in touch with people who could support them if they had questions. I even had people calling me at Kemet FM, the urban station where I do a health slot, to say that, sorry, family members are leaving, that they needed to continue to be tracked. But what we found over nearly 7 years is we've lost one to Derek, we lost to COPD, that's pulmonary disease. Another gentleman had a heart condition, but we have not lost those men to prostate cancer. We have not lost any of that support group to prostate cancer in nearly 7 years. So we can change things. And the same thing, we did a Hearts and Mind project that was funded by British Heart Foundation, but we actually did it ourselves. We designed it, we delivered it. We worked with celebrity chefs, who had written a Caribbean menu that was less salt, less sugar. We had a character called Miss Patty Dumpling who went out and raised awareness. And I feel the same way. We saved lives. We had aerobics. It wasn't just, doing aerobics. It was exercising to reggae music and the music that we know. We know that people lost weight. Even one of my cousins, she lost weight, and then some years into it, she had a mild stroke. Now, I believe she hadn't lost that weight, that stroke would have been worse. So we have done things practically, but with the vaccines, I was raised at a time when vaccines weren't there for our generation. So I was raised with kids who had their legs in calipers because they had polio, with particularly boys who had mumps who then became sterile. My sister had whooping cough. It was terrible to listen to. We all had chicken pox, but we had measles and everything. And it made people really ill. And just recently, because my immune system has been battered a bit by the treatment and by having the cancer, my daughter has a long-term condition that causes abscesses, which we don't know where that came from either. But she had to go to accident and emergency because she couldn't get one of the doctors to actually understand that she needed to get something for it fairly quickly. And I had to sit in A&E the whole night. And I said to my daughter, I should not be, there's a protection for me. There's no mask or anything. And that's another thing I feel very strongly about. Should have been advised to wear a mask from the beginning. I advised the group to do that. And none of the Sistas Against Cancer got COVID, and neither did
Very
FAB.
good. Very good. So Rosemarie, I just wanted to say thank you, because you've wrapped up and succinctly sort of placed a point of regards to the vaccinations and the negative associated with not having vaccinations. Obviously, growing up in a time where they didn't have them, it is a choice. And so the other question I wanted to just wrap up with the last question of the night was, Enid Brown has stated it cannot just be the underlying health issues why so many of our people have died. We have the same conditions in the Caribbean where the death rate is very low. And I think, Tony, you touched on this a little bit earlier. So care to just elaborate your comments?
Yeah, can I just go back to Jennifer Beth Blake's question? Because we also, and I want the listeners and viewers to hear this well, we also need to take on board our own, we need to be responsible as well in terms of our physical activity, in terms of our diet, in terms of things that we do or we don't do, to enable us. We talked about, asking GPs, doctors, healthcare professionals to enable and empower patients to make the lifestyle changes. We have a degree of responsibility within our own selves and within our families to cook healthily, to do various things that will keep mind, body, and soul ticking over. So we mustn't lose sight of that. You're in control of yourself and can decide, well, I'm going to make the lifestyle changes. So Jennifer Beth Blake's question is a very vital, crucial, fundamental one, which we must not lose sight of. And I say that to people all the time in terms of, as Black people, We do need to wake up and smell the roses or the coffee, whichever one you want to prefer. So that's that. But in the other part of the analysis, as was touched on earlier, yes, the deaths in the Caribbean and in Africa are nowhere as near. Is it to do with, and the jury is still out because of the abundance of sunlight, so they're getting vitamin D? Is it to do with a better immune system or what? Because there is diabetes, there's hypertension, there's chronic disease, all of the various underlying health conditions mentioned in the UK and the United States exist in the Caribbean as well. So there has to be some more research done as to why is it people in those areas are getting the virus, but are not dying in the multitudes and the multiple numbers that are happening here in Britain. And I'm sure there has to be the socioeconomic factors and the health inequalities and the lack of education and awareness, which is where likes of me and Rosemarie come into the equation, alongside the healthcare professionals, to educate people about eating well, getting a good night's sleep, getting rest, doing physical activity, Jamaica Moves, which Corey is very much involved in, getting people to do more movement. We're not supposed to be sitting down on our posterior for 7, 8, 9 hours a day. We're supposed to be out there doing all the various things, line dancing, cleaning the windows, mowing the lawn, fast-paced walking, swimming or jogging, all these sorts of things.
All those things. Thank you.
Just walking.
Thank you so much. Yeah, I agree, Tony. So, Tony, just a quick question, reply. So you said you got to smell the coffee. Is that Blue Mountain coffee? They're blended in what? Those who want to try the rum, then that's another issue. My father used to say, food is the staff of life, but rum is life itself. Fantastic. So I just wanted to try and wrap up the discussion because we are on an hour and a half now of discussion, and we could go on for another hour and a half, I'm sure, with quite ease. But I wanted to just see whether you could just summarize for me your thoughts on today's events, just in sort of 1 to 2 minutes here. So we'll start with yourself, Rosemarie.
I'm delighted to be part of this because I have a busy life. We spent a lot of time on the phone reassuring people, but it's just been great to meet with others who are Jamaican and who are academics as well. And Tony, I know you don't see yourself as a health professional, but you probably know a lot more as far as cultural competence is concerned in health than most colleagues that I have. So big yourself up, man. Thank you for this. I just want to echo something that Tony said. My husband nearly died of heart attacks because of high blood pressure. And he didn't even know he had it until I sent him to the doctor. Women, sometimes we have to do that. But he was basically had a thickened heart muscle where the blood pressure was going into his heart. So we had some blue light moments, and actually he was put on medication. Then we just started working on his diet and reducing salt, and he managed to come off all the medication. I bought a blood pressure monitor, and because things have been so stressful, just keeping the organization went up again when I was ill. Do you know, since COVID, he's been walking every morning and his blood pressure has come down almost normal. Exercise is really, really important.
Fantastic. Can I just ask a key question here, Rosemarie, about there's a question I've got here. How do you access the workshop with regards to Sistas Against Cancer? Can you just give me a snippet of how people would access that service?
You can actually do it through actually emailing us at service@bmecancer.com, or you can call at 07, we'll put it up afterwards, 07492 830 786, and we can actually then we need you to agree with the group agreement because it's a confidential group.
Right.
So we'll send that to you. Once you've agreed to that, we set up Zoom meetings about every 2 weeks. In fact, I should have had one today, and there was so much going on, I had to postpone it till next week.
Sure. Thank you.
But you can join our Zoom meetings. If you are a patient or who has cancer, this is for the women, the men have their group as well. Or if you want to go on the men's group for prostate cancer, you just go on to Friends and Brethren's prostate cancer website. But
Perfect. Thank you so much, Rosemary.
830-786. We'll put it up.
Excellent. And Tony, your thoughts on today and just wrapping up?
Well, for me, it's a continuation of what my mother and her two sisters started from back in the 50s. And here we are with all this new technology, continuing the same discussion, etc. But I'd go back to what Rosemarie said in terms of cultural competence or cultural diversity, whereby a lot of patients and a lot of Black people out there, African, Caribbean, and Jamaican people, need to see the likes of you, Kevin, and David, and Rosemarie, and myself, people who they can relate to, people who know about the Jamaican language, people who know about cassava and yam and plantain and dumpling and so on, and can use words and phrases that they can, proverbs and so on. Because when I go into some of my events and talk the Jamaican language, people say, that's what I want to hear. I'm hearing it from somebody without them speaking like with a hot potato in their mouth. It resonates with them. And seeing somebody of your own hue and color is also very important in this very grand scheme of things in terms of our health and our wealth. The two go hand in hand, and our physical health and our mental health. And I've thoroughly enjoyed tonight's discussion.
Fantastic. Thank you so much, Tony. Before I bring in Dr. Brown, I just want to mention, obviously, we've got our handles here. So we've got a Twitter handle of @official JDUK. We have our Facebook group, and I'm sure you're already on live via Facebook if you're not watching on Rewind, at JDUK National. And we also have @Jamaican Diaspora UK for Facebook. Dr. Brown, what are your thoughts here as a wrap up?
Well, I guess the first thing to say is thanks to everyone on the panel and for those who are listening and sending their questions. It's been really, such a heartwarming conversation insofar as listening to us tease out the problems and also identify, positive solutions going forward. And the key thing to remind everyone is that this is the beginning. This is the launch of our health series. We're aiming to have 10 more online. We have stepped up to the new normal. And although we traditionally the Jamaican Diaspora has events where we meet face to face. And as a community, we do like to socialize physically, but such are the constraints that we're now doing it online. And I'm really excited by what we have planned in the next 10 or so episodes. And I hope everyone will return to join in, because health is crucial. Health is life, and it certainly determines your quality of life. And so we want to see if we can help by having experts like yourself, David, Rose, and Tony to speak about, their respective expertise on these illnesses that affect us. So my final words are just to encourage everyone to keep safe. Those who are self-isolating, I hope that the restrictions will be lifted soon and that we can be together once more. But I'd also encourage everyone to, make sure that we're looking out for each other, friends and families, make sure we're still calling people and just checking on them, and we haven't left anyone sort of isolated or alone. So as a community, I hope we can continue that great Jamaican spirit of communal, engagement with each other. And I'm sure that the party days will return, but maybe not for some time soon. But in the meantime, we hope to continue that engagement. And as I said, you read out the social media handles, David, and I hope that our diaspora members and supporters will now sort of engage in this virtual medium, this virtual space that we're using, as it will be, the future for now until the government says otherwise. So thank you, David. You've been a brilliant moderator, and thanks to our sponsors, Victoria Mutual, and our partner, Jamaica Moves UK, and Corey Hyde.
Thank you so much. So as you've said there, Kevin, essentially this is the first of a series of monthly deep dives into further issues, including stroke, mental well-being, prostate cancer, lung transplantation, sickle cell, eye health, breast cancer, diet, exercise, nutrition. We're going to touch on a whole host of things here, and I hope you will be with us on this journey through the health and well-being arm of the Jamaican Nationals, Jamaica, chaired by myself, Dr. David Burton. It's a bit strange talking about myself in third person there, but chaired by myself, and I hope we're on to sort of big things in terms of how we move forward. The last thing I'd like to say is I'd like to thank the panelists, Tony Kelly, Rosemarie Thompson, Dr. Kevin Brown. Also like to thank obviously our sponsors, Victoria Mutual, and our partner Jamaica Moves UK, fronted by Corey Hyde there. JDUK Public Relations Officer Sophia Ramcharan, and also Wayne McIntosh, and members obviously of the Jamaican Diaspora UK Health and Wellbeing Working Group. And to those who are listening, I'm really thankful for you joining us on this Windrush Day, and I hope you had a festive and beautiful day via alternative methods. And I hope in a year's time we can all meet together and have this forum in a more closer circle, and really chew the fat in that regard. And I also like to thank obviously those people who sent in questions, and I really hope that you got something out of this. The first meeting of the Jamaica Diaspora Health and Wellbeing Arm, launched obviously on Windrush Day. Thank you for joining us today. Good evening, everyone.
Good evening. Good night.
Good evening.
Awesome.
Release that mouse. So this is what you're doing at work? Eh? Online shopping? Hey, Mrs. Richards. Aren't you looking lovely today? You think you must be able to shop online? You don't need no more clothes. What you need to do is stick to the iSave plan so you can get your dream house. The key when faced with temptation is to walk, run, or roll away from it as fast as you can.
And later on today, we're going to transfer some money to your iSave account using VM Express Online.